Really nice perspective and insights on our virtual verification. We're going to let each speaker talk for about 20 minutes, and then we'll allow questions at the end. So for the sake of time and the presenters presenting, please save your questions till the end of each speaker, and then we'll go over questions then. You can utilize the chat or unmute to ask questions when we get to that point, and we will go ahead and get started. Dr. Tinkoff, are you on the line? All right, well, while we're waiting for him to get on, Dr. Chow, if you want to go ahead and do your presentation, you can start us off.
Okay, let me share my screen if you don't mind. Right, do you see this PowerPoint Trauma Verification 2021?
Yes.
Okay, so just give me a little background on myself. We're a level 3 ACS COT trauma center. I've been medical director here since 2010. Because we were not a trauma center prior to this, I had to go through a consultation visits. And so I've been through about 4 verification visits since that time. We were very fortunate to pass due to my great team that I have. But they were all in-person verification visits until last year. So we are actually scheduled for this date in 2020. But of course, you know, COVID hit, and literally the day before verification, we were notified that they were canceling the verification visit because the reviewers, their home hospitals were not allowing them to leave and come back without being quarantined. So they could not go through that. So we had a 1-year reprieve, which was very helpful. But we weren't notified but that this was actually going to be a virtual visit for about a couple months earlier. And so at that time, it was unknown. They were kind of going through their preliminary visits. They were trialing different sites. And so through a TQIP conversation and I think presentation, I got wind that there was one level 3 trauma center, I think it was in Texas, that went through the virtual visit. And so what we did was we contacted them, and they were a great help. And I apologize to that person that I cannot remember their name, but we did get some insight into what to prepare for. So we started preparing right there and then. So 60 days prior, we got the VRC saying, hey, this is the site visit that you're going to go through. This is what we expect. And these are some questions that are frequently asked. And so we started scrambling because literally 30 days prior to that visit, we had to submit data. And so all the charts that we had pulled for 2020 were in physical charts, and we had to start scanning them. And I'll show you what we had to do to present it to them. And so it was a lot of work, very labor intensive. Fortunately, I think whoever's going to go through prior to this will kind of get a heads up a little sooner than 60 days well, essentially 30 days to get the data in. So after 30 days, they'll send, and they kind of played with the timeline because it was a first, kind of one of the first institutions to get verified this way. So we did have to send them charts to be reviewed, and then they will pick charts and bring it back to us. So they'll give you a list, and I'll show you the list that you need to submit. And then they'll send back 20 to 25 charts that says, hey, these are the charts that we're going to be reviewed virtually. And then 7 days prior to the visit, we need to submit everything. Of course, your PRQ has to be in, 30 days before that, along with your data. So, a lot of work to do up front, but I think that if you get a heads up, I think it's not going to be as bad as you think. Now, one thing that you want to do is 1 week before the verification, you really want to get prepared with your technology. And I'll show you what we did, but we had some bumps in the road. Each institution is specific on what they want to use and how they're going to do their IT. So it's very, very time consuming. So this is what they're going to send you. It's totally different from the injury categories that were prior. If you remember, they had like some of the ISS greater than 25 and liver injuries. Now they give you specific systems, and then they break it down even further. And so we actually had to go back to our charts, reorganize and regather, and then submit them in this fashion. And they'll send this to you, so I'm not going to belabor this anything specific. But the key is it's going to be different than what it was before when you did a regular visit or a in-person visit. They're changing the aspects of how they're reviewing centers, and they're really going to focus on PI, and that's going to be one key. And I'm not a reviewer. I think Dr. Tinkoff and others may be reviewers, so they can give you a little more insight in that. But they really focus on PI, and I kind of knew that, so I kind of really prepared for that, and that really helped. But these are the categories that you're going to go through. We're adult only level 3, so level 1 trauma centers and adult and children is going to be totally different than you. And obviously, you have a lot more resources than I do, but this is how they're going to break it down. But one thing is going to be different is going to see, okay, who are the key players to have a virtual visit and make it work well and smooth. And that's the key. So one thing that we know at the top of the slide is the video conference platform. Zoom has been used on multiple occasions, but our institution does not allow Zoom because of the security issues. So we had to use Microsoft Teams, which has some is very you have to have IT help you to set up creating different rooms, because what they want to do is as we talk about this, they're going to have virtual rooms that you're going to have to set up. So I'll have be in one room, or my trauma program manager will be one room virtually, if you guys can conceptualize this. And then the reviewers will be with what they call a navigator. So a navigator is what role do they serve, and you can read that on your own. Now, some people use clinical coordinators, but you cannot use your trauma program manager. You cannot use a registrar or your TMD, okay, or your on-site coordinator, which is going to be separate. What we did was we did our trauma APPs. They're certified nurse practitioners. And the reason I chose them is because they round with us every day. They go through the chart every day. They know exactly where the progress notes are, the nursing notes are, the images, how they bring them up. And so they can really navigate through the EPIC. We use EPIC, our electronic medical records. And the key is they have insight into the clinical aspect, because sometimes, although the reviewers said they wouldn't be asking questions, they did ask about, okay, what you guys do for this? What is the thought process? How do you PI this? And so I'm very fortunate that my APPs are involved in my PI process, and so they kind of know the process, and so they could chime in. Now, if the questions got a little too clinical, they would break out of their room and come back to a separate room and to ask me questions, and then they'll go back to the room. I'm happy to answer questions about that if it's confusing. Now, so that navigator will go one-on-one with the reviewers during the chart review. Now, we did pick a medical staff to be our on-site coordinator. This is very important because they have to do all the logistics. Got to make sure that all your physicians know what time, when to be on, how their IT platform is being used, how to log in, how to ask questions. And I made them remind them 2 days before, hey, you're going to have to be at this time online. And then what happened was we ran ahead. And so we had to call everybody and says, hey, can you move up? Can you move up? Well, some people are clinic, some people are not, some people are available. It really worked out well, but this on-site coordinator was very, very helpful because she had a lot of knowledge about EPIC. She had a lot of knowledge about, she had everyone's phones numbers, home phone numbers, and we made make sure that everything was smooth. The more you prepare, the smoother it's going to be and less stressful, because the day is obviously very stressful. So these are and they'll send you more information about this, but these are the key people that you're going to have. So our reviewers were Dr. Salim and Dr. Mong, and they were you probably know some of them, and I'm sure Dr. Tinkoff does. We were very nervous because I've never personally met them, didn't know them. I did contact them on some occasions, but it was very nice that 1 week prior we had a sit down review and say introduce each other. We had a nice conversation, what the expectations are, what their expectations are, what our expectations are. We had a very good conversation, and we really went through the program really well. They were very kind and thoughtful. They gave us good insight. So as you all know, it's if you've been through a review, sometimes that can be reviewer dependent, but we were very lucky, and I've always been very lucky with the reviewers being very courteous and kind and allowing us to focus on the program. And you know, I tell my team, you know, this is our time to shine, and their goal is to find problems. They will find problems, and we want to hear about the problems because it makes us better. So they're very nice and allow us to give us a lot of education on how to get better. So this is what we did. We have a very small office, but at this, if you can see my arrow, at the far end near the screen is Devin Skierman. She's one of our trauma APPs. To the right is Ashley Rashan. She's our PR coordinator. And this is Ben with IT. And so this, if you look to the far left, these were our physical charts that we had to scan in and create online to Microsoft OneNote. And I'll touch on that for a second. But it's very important that you get people engaged, and we literally had 30 days to scan everything, organize it, reorganize it to the categories that they wanted and how I wanted to present it to them. And so they did all the work, and to have an IT guy here is paramount. You really need to identify one IT person, make sure that they know how important verification is and that they're going to engage with you and be available for you, not only throughout the preparation process, but also at the time of verification. Because if you have issues, they need to troubleshoot right there and then. So this is what we did, and this is what a template that they will send to you. And they'll break it down to categories, and you kind of fill all this in and send it to them. And this is that charts, the categories that you will fill out, send it to them. Then they will pick patients out of this Excel template and send it and say, we're going to look at number 1, 7, 10 or something, whatever. And that amounts to about 20, 25 charts. So OneNote is what we use because it was something that was offered by the college. There's other one, I think the college allows you to do any type of software that you would like to do, but we use this because it was very nice for us to set up by the categories that they wanted. And so whenever they say, hey, let's go through abdominal thoracic, we open that folder up and we'll have all our patients that they had listed earlier. And then we just broke it down to everything that they had wanted. Patient summary, pre-hospital, and just click, 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 click. And we had scanned in every of the flow sheets, our history and physical, and everything they want to see something, click, click, we'll bring it up. Now, during the verification, they will have your, we had the electronic medical records available to us, so we can always go back and forth. But using this platform was very helpful because it helps to be organized and have everything in one place. And I think this is also important that you send it to the reviewers and they be prepared for this and they can review through this. Like I said, we did use OneNote and it was useful to us, but it was a learning curve. So no one has used it in my office other than the IT guy. So the IT guy is so important because it's kind of quirky, and so you need to have someone that can help you through that. Now, we did Microsoft Teams. You may have some questions about that, about the how to go in and out of the rooms. We finally figured it out, and it was useful. So this is how we set it up. Oh, sorry. So before I get to how we set it up, this is just what we did for medical records. We just had all the notes scanned into the OneNotes and presented it this way. And so we had everything they asked for. In addition to, if I thought, as I was going through the charts, that it can give the reviewers some better idea of how it worked, what actually happened to that patient, as well as our PI process, and it flows well. I want them to think as a clinician, the patient coming in and flowing. I want to present it in that fashion. And so I was really diligent in going through the medical records, and my team got frustrated sometimes, but if you look at how you flow, it's a lot easier for the reviewers, and it cut our medical record time probably 45 minutes. So that's important. So this is how we set it up. We have 3 large conference rooms, and we actually thought about, okay, so if you have virtual rooms, let's do each individual physical rooms. And so this is how we set it up. On one side, we had, this is where, can you all see this arrow? I'm circling this computer. Can someone just let me know whether you can, anybody can?
No, cannot see the arrow.
I can't see it. Okay, but anyway, if you look at this top left picture, you see the TV screen. Below that to the left is a computer screen and a table. And then, so this is where the computer screen and table is where the EMR and the navigator would sit. We had a TV screen mirrored to this computer system so I could see what was going on and listen. Although I was physically away from that room, there was a virtual room all on their own. I could physically see what was going on, so anticipate any problems or issues. Now, one thing is we have, if you look to the right of this top left picture, to the far right is a bigger monitor screen. So we use that in case the reviewer wanted to talk to us one-on-one, we would go and stand in front of that. We kind of may, you don't need all that. You really don't. But I just wanted to make it flow easier for everyone. So that's what we created. So if the top left picture is one room, the top right picture is another room, and separated by another room, because sometimes the audio you can be heard. So we actually ran this about 2-3 times to make sure we got the audio right, make sure people couldn't be heard overseeing each other, make sure I could hear what was going on in both rooms so I can anticipate any issues or problems. And then the last and most important thing is I had snacks for my navigators so they wouldn't get hungry. So that worked out really, really well, and I think the reviewers liked that. So day 1 of your agenda, you're going to have brief introductions. Although you do this 1 week before, we just now we have everyone who's going to be involved in the verification. Your administrators, your other physicians, staffing. So there's a brief introduction, and then you go straight to your medical records, and that's where they start breaking out into rooms. You always have 1 navigator per reviewer. And they're able to navigate through the charts, and they'll go through the charts. They'll look at your PRQ, they'll look at the processes, they'll look at your data, they'll look at the chart, and they'll ask questions. Can you show me this? Show me this chest x-ray, show me this CT scan, just to verify, verify what you're putting down in the charts. Make sure that as you go along, that you're doing your PI process. And sometimes what they would do is they would ask about the PI process to my navigators, and I instructed them, if they actually do that, you may want to call me over and ask the question, or if I feel comfortable enough that they are very talented that they're going to tell I give them, say, you can answer however you want. We're not hiding anything. But if it's too difficult and they don't know what the thought process was for the trauma medical director, then obviously I'll come in, or my trauma program manager. So that actually took, it was scheduled for about 4 hours, but took about 3 hours. So we ran far ahead of time. The TQIP report was scheduled for about 1 o'clock. We pushed that up. So we went through the TQIP report. They did a nice thorough job. I was able to ask questions. I could understand it better now, and they gave some insight into that. So that went really well. And then after that, they started going through all the program documents that you sent them, and we sent that in OneNote. So a separate folder, call schedules, trauma medical director, CV, CME, all our roles and responsibilities, so forth. And then the last part of that day 1 is where you have the review committee. This takes place of the dinner meeting that they've had in the past, where everyone comes in. Now, this the challenging part is the on-site coordinator has to really make sure that everybody's there and on time. And so, in fact, the issue was we were running ahead of time, and I had offered to, hey, let's get this done earlier, and we were able, the on-site coordinator, we're able to contact everyone. We're able to move it up almost an hour, so got it done quicker. Now, one thing about that is I always tell my physicians, 1 day ahead, no, 1 week ahead, 1 day ahead, be available, drop everything. You have to have your own separate space, be in your own office. Can't be in your dining room with your family around or dog around. Yeah, have your own separate room so it can be heard and you can hear the question. And so I really emphasize that. That was very important. Then they went over the PRQ discussion like they usually do, and they asked specific questions to the liaisons. As trauma medical director, I kind of moderated to make sure that in case there's questions that couldn't be understood, I would jump on in. So, and then so this is the actual review. This is Devin again, trauma. If you look at the left, she's at the screen. She's in Epic. We had an extra monitor. That's important. Get an extra monitor for your navigators so they can go back and forth, so they can slide the CT scans to one side, but still yet see your medical records on the left side. And so you have different options. Instead of having to click through different folders or different tabs, you can slide it back and forth. We had the monitor up so I could see what was going on. And this is Dr. Salim talking with Devin and kind of going through the chart. Again, I was separate away, out of his view, but yet I was listening to make sure, hey, what's going on? What is he asking? There's going to be cases, you all know this, right? Cases that you're going to be kind of nervous about, that you're going to be, okay, is he asking about that case? Okay, what is he asking? What's going on, right, etc. So day 2 is a hospital tour, and this is different. Usually they walk around, but this time we had it's on a virtual platform. So they recommend doing either a laptop or a video phone. The video phone is kind of hard. What we did was we have computers on wheel. We actually bought a Bluetooth speaker that could attach to that and attach to the speaker's voice. And that's what's really important. And test it out. I did it 2-3 times. I did it with a lot of noise around, with noise, without noise around, how you're walking. I walked through the virtual visit route 2 to 3 times just to say, okay, what's in my mind, if I was a reviewer, what would I do? What do I want to see? How is it going to flow? And then, of course, on the day of, you make sure that there's people that you want to be interviewed. If they interview them, that you want there, right? And so you always tell them 1 day ahead, okay, you're going to be on, who's on? What are you going to say? This is what they may ask you, okay? And this is what you're going to say. Don't lie. Just tell them the facts. Don't tell them the facts. And then, so it went really well. So we went around and I kind of narrated, kind of talked about what went on, what our physical plant is like, why we have it this way, how it compares to everything, what our challenges are, what we have improved, and what we want to do and to get better in the future, but also how it works for our trauma patients. So once that's done, that one took about, I don't know, 45 minutes and went really well. And then now, I'm not sure if they do this on every verification, but they usually have separate TMD and TPM meetings, but for some reason we met together. And so I thought that was difficult because sometimes if you have some concerns that you have that, the medical director's thought process and TPM sometimes, you got to be fair and honest. And sometimes, having that separate meeting is helpful of what the needs are. But it went well, and then they met as always. They kind of did the review, did what they have to do. I'm not sure, I'm not a reviewer again, but they did what they have to do, collated a summary, and then did the reviewing, closing meeting, and exit interview. So the day ended on the second day, probably about 11:30, and so it went really well. So this is the second day. This is my team. Again, always have your IT guy with you in case you have faults. I walked the route 2 to 3 times looking for dead spots. So in case I lose my the verbal ability, the Bluetooth speaker doesn't work, it's the interference, things like that. Make sure you can get good camera angles. What do you want to see? So this has been our IT in the far left. If you look to the right of him, or far left of this picture, is the computer on wheels that we have. And that is actually, we mounted a camera, and this is where the Bluetooth was, and we can just push that around, narrate. I had my far right, my program coordinator there, my registrar there to the next, both my trauma advanced practitioners, ER staff, because this was an ER. So valuable, of course, your team is the most valuable asset that you would ever have. So final thoughts, just be organized. You have to be organized. Think what they want, but organize how it works for your institution and how it will flow for you. The IT and coordinators are probably the most important, but the navigators is not inside, but they are almost as important as anybody you're ever going to use. So pick, choose those people wisely. The virtual tour was effective. It's different from online, but I kind of like it. I kind of like how they did it. I know I think they're thinking of sticking with it, but I think it's effective. So I'm sorry to take up too much time. This is my staff. Far left is Dr. Alexander. She's my trauma medical director. And then my APPs are out in front. We have my prevention coordinator, registrar, program PI coordinator. To the far right is Lindsay. She's our navigator. She works with medical staff. So any questions? I'm sorry I went pretty quick, but
is it possible that we can get the slides?
sure, I'll be happy to send whoever's.
This is Ginger Schwinn. I mean, maybe, I don't know how they're coordinating this lecture, if you want to just say, but it's very helpful. I took quite a few notes, but we're looking to become a level 3 trauma center. We're just starting from the ground up. So
And what state are you in?
In Ohio.
Oh, what?
We're St. Luke's. It's McLaren St. Luke's in Maumee, Ohio.
Oh yeah, wonderful. Are you a Pro Medica or you?
No, we divested from them maybe 3 years ago, and we were on our own. And then now we just joined the McLaren system.
Oh, wonderful. Yeah, I'll be happy to share slides, discuss things with you. So, since you're in Ohio and you've never been a trauma center?
No, and actually, I've never even worked in trauma. I've been here 35 years as a nurse and worked in surgery and ICU, and I've been in leadership for about 8 years. And so they asked me to start up our program. So we're just developing our team now and, learning.
You know, in Ohio, you have to go through your consultation visit. Probably all know this, but the Ohio Department of Health, you got to get the permission. You got to create a PI program.
Yeah.
Yes. So, and then you need to have some year, like a year of data, and then you can get verified. But you can really push it up. I did it in 9 months. So, if you want, I'll be happy to talk to you more one-on-one, what we did, how we did it. Give you like templates that we use. That'll be very helpful. And happy to share the slides and however you want to do it.
That'd be great. Yes, you could include your contact information somehow that we could get. That would be awesome.
Yeah,
I'll
Dr.
give it
Chow,
to,
this is Alex.
Yeah, Alex. I'll give it to Alex.
If you want to send it to me, and then I will make sure we get everything out to the group. So even if there's other people that may have some questions, then we can get that taken care of for you guys.
Great.
You have my email, right?
I do.
Okay. All right.
I think Ashley, are you on the line?
I'm on. I can send it to her.
Ashley Rashawn is my PI coordinator. Hey, did you want to throw in any thoughts about verification and the virtual platform? So this is Ashley's first verification, but you have any thoughts or comments?
I think you touched everything. I would just, reiterate being organized and practicing. We practiced multiple times, and that truly helped clean up some of those issues that we had. And honestly, I felt like the day went very smooth. because we were able to wean out some of those issues early. Practice was key. Organization. The OneNote it was challenging to create, but they basically give you the template on how they want it. And then it's just timely. So if you have somebody that can upload all that information, like Dr. Chow mentioned, our APPs were phenomenal. They would scan everything to my email and then I could upload it from there. So if you have that extra person that's able to do that stuff, that's truly helpful as well.
This is Tracy. We have a verification. We have a consultative visit in July, and I've spoke with our lead reviewer and our nurse reviewer, and they are not using OneNote. They don't want to use it now. They said they've had some issues with other reviews, so their recommendation right now is SharePoint.
Yeah, I don't know how to use that, so yeah, good luck. Yeah, definitely. I wasn't a big fan of OneNote, but you know, because I had the IT specialist, we just kind of went with it, and he was super helpful. So, yeah, good luck on that. And I'm sure any platform will work as long as you can organize yourself, and when you're at this time of the review, you can just kind of go through it seamlessly. That's the key. Yeah, that's the key. Any other questions? Yeah, if anybody has any questions anytime, I'll share my contact with Alex. And happy to shoot me an email if you have any questions, or even if you have comments and I can get better, please let me know, and how I can get better, and any tips that you have for my next verification coming up in 2024. So thank you for allowing me to share, and I appreciate it, and take care.
Thank you so
Thank
much,
you.
Dr. Chow, and Ashley for adding in. So next up we have Dr. Glenn Tinkoff. And Dr. Tinkoff, I don't know all of your accolades, so I'll let you kind of speak through that and where you are. But Dr. Tinkoff, we're so thankful to have him join us. He is an ACS reviewer and has also gone through a recent visit himself. So he's going to add in and give some insight from both perspectives. So I will go ahead and let you take over. I think you're muted.
So, can you hear me now?
Yep. Yep.
Thank you, Alex, and thank you for the invite. I have not spoken with this group before. I've heard a lot about the group, and actually in the reviewers group, this group is well known and is actually been commended several times for its activities nationally. In Ohio, but from a national model of collaboration. With that said, I've been a COT and VRC reviewer for over 20 years, and started with the VRC program when it was conceived. And this has been a huge change, probably the biggest change since the start of the review program. The review program was meant to be on site when it started. My background is I was in the state of Delaware, actually. Now that we have a president from Delaware, finally people know what Delaware is. And Christiana Care is the major healthcare organization in level 1 in Delaware. And I was the trauma medical director. I was also trauma medical director of a level 3, as well as other positions within that institution. I am currently at University Hospitals in Cleveland, Ohio. This is a rather large healthcare system in Northeast Ohio that now has 8 trauma centers, a level 1 University Hospitals at Cleveland Medical Center. I'm sure colleagues of mine are on the line. And a shout out to them. And level 1 Pediatric Trauma Center at Rainbow Children's, and we have 5 level 3. So they're through various stages of verification and provisional status, and an affiliation as well with a level 3. With that said, all these facilities are mired in the verification process that Ohio demands, using the American College of Surgeons approach. The verification visits the virtual verification visits have started in system, with one already having occurred at one of our provisional sites, and one due next week. And I just finished my first visit at West Virginia University Hospital. So my insight into this process. Obviously, everyone here remembers, I believe, last spring, when the visits stopped abruptly. I was in Michigan at that time, finishing up the last visit before. Matter of fact, the minute I got off the plane at Hopkins, I was told after contacting college there was no more visits, and my visits were canceled from that period of time on. The year hiatus occurred. The return has been handled very well. Back in December, the VRC leadership, the Verification Review and Consultation Programs leadership, tested several centers with virtual reviews, and they were doable. And they've come up with a fair amount of reviewer orientation material that I'll go over with you, so you can see it from the side of the reviewer. I think the talk that just went on, and I'm sorry I came on late because I'm in transit right now, trying to get back. I haven't seen my family for a while for Mother's Day, so I just reached my wife last night. So basically, I'm in my office at home. So anyways, with that said, the material that we're given and the orientation that we've been given has extended based on the talk that was just given along the same lines, an understanding of the agenda. We have to front end a whole lot more in this format. And what does that mean is that a month before, many of us, because we're not, I know it comes as some surprise, but most of the trauma surgeons you probably know are juggling a lot, and the reviews come up on them pretty fast, and a lot of the preparation is done days before the visit. And obviously the charts are not available to us beforehand in the on-site visits. So this was all new to us. And the virtual format, obviously many of us are in my age group. We're not technophiles. We'll, like today, I have several computer screens open, but I'm on my iPhone because it's the only one that worked to get on Teams. So I'm thankful to have gotten on. But the fact is many of my colleagues are in that senior age group that needs some help. One thing we do want to talk about and it is in the pre-review checklist in the FAST. Realize we signed the contract that's signed and with the college to do verification visits, that the reviewers are already quote unquote HIPAA compliant with your charts. Or you're asking us to review your charts. So once the record gets to us, it is our responsibility to treat them in a HIPAA compliant way. So you know, that's been a concern that we may abuse or misuse that, but we are counseled in that, and we are to destroy the material if it gets into our hands in some fashion. The HIPAA compliance of the video conferencing platform is what you need to be mindful of, and make sure that that's that platform. Most of the platforms are that you're going to work with. Zoom is considered that. Teams is, as well as most of the major platforms. The visit I did, we used a SharePoint approach, and it worked very well through Teams. We have used Box as a place to place charts like OneNote, and I will point out that charts must be tabbed. And fortunately, they've asked you not to send imaging and not to send progress notes now, and I agree with that. We'll ask for progress notes if we need that. Really, summation material is about the most we can get through. And what we're trying to do is get the case narrative down before we come on board, making sure, and that's why it speeds up the chart review, because we're coming in with an understanding of the case, and we're asking you to, we're asking the navigator and the facilitators, which are what was discussed, the navigator being somebody not in the clinical end, really somebody who knows how to move through a EMR of a trauma patient in your system well and quickly, so that and most of the things we're going to do is validate what we're already coming in with by knowing the case. So that's important. Now, I will point out that the pre-review checklist that we're given is important to understand that we know the preparation, but a month before, we're asked to contact the center and generally with the trauma discuss with the trauma program manager logistics and also with our and then contact our colleagues and whoever we're visiting with, and make sure that those logistics are done. We then receive the listing of charts, and we're once we receive that within a week or within 5 days, we should turn that around and have that back to you. Depending on the visit, it's generally 10 charts per individual, with some extra charts may be identified because we may make that choice during our review period a week before coming or entering the virtual visit or the visit. Once we have once that 30-day prior call or contact occurs, really the clock is running on the visit, but most of the activity is centered in that week before. Our expectation is that once we're in the charts are complete. Meaning that basically your modification of the chart material has occurred, and if there are problems, obviously expect a call. We were on with West Virginia. We were on several times with their IT people to help us navigate their virtual virtual environment prior to the visit. Once the day of the visit or a week before the visit, there's a logistics call with the team, with the trauma medical director on call on there. The agenda of that call is really to introduce ourselves, to get an introduction of those on the call. You should have certainly your team on there and who we're going to be working with, and any observers you may have, so that we know. It's a time to ask questions, clarifications, any concerns. Discuss just what you're discussing here. What are the best practices the reviewers have exposed to? Many of the reviewers are just now doing their first or second visit, as myself. So our feedback is limited, but we're getting used to it. We've heard some of the concerns and and many of the clarifications from our leadership, and the best practices that you have undergone in previous in any previous visits you may be aware of. Once those are clarified, the software expectations and any tests you need us to have with our own software at home. Remember, it's a myriad of technology that is being used, and there are myriad of places. I've done portions of the review in my office and portions of the review in my home office. So we may be using different activities, different technologies, but also it's important to understand that one of the key people is giving us the contact number to your IT people, the coordinator who's helping us move through these technologies. Also discuss, introduce us to the navigators. Make sure those are probably the people we're going to be working closely with, or going to be closely working with during the case reviews. The PI documents and what they're going to look like. That's a good time to mention them. You might even want to test the hospital tour modality at that time. Not give us a tour, but at least have that equipment there, turn it on, and make sure it works. And make sure that we can that on that meeting a week prior that we can get in the EMR and and review it with you, so that that technology is available. If that goes well, it generally is maybe 40 minutes on the phone, maybe less. If there's problems, we may have to have another call. We did that in West Virginia. And in our own centers, we haven't had to have that repeated. On the day of the visit was very well described in the prior session, and I won't go through the agenda specifically, but just comment from a reviewer standpoint what that agenda details. We're coming in. I think one of the real positives of this virtual visit is it allows for a PowerPoint-driven discussion or presentation by generally the trauma medical director of the history and the positives, really, of your program. That's been very helpful, honestly, and a lot. And I would suggest that a lot of pictures come up in that, in terms of your facility, because we're not at the facility, and of your culture. One of the things that's missed by not being on site is we really can't get a feel for the culture of the institution. So here's a time to really be positive about your program and let us understand that. Also, why, who you serve, what are the communities, and what do they say about you? And those are important messages, because the dinner is not. It was used to often have those type of comments from administration. There's not as much time to do that. Here's a place to do that in. So that's a very important opening session and sets the tone often for the rest. It doesn't have to be long, but it has to be focused on those things. Tell us about your program. Tell us about your positives. Second is chart review. That's logistically challenging for many places. We did it in one big room. There was some, this is at UH, and that works. There is some audio issues that sometimes happen with that configuration. If you have a fair amount of rooms, separate rooms also help. The nice thing about having one room is you can have in the background, you can have your trauma medical director, your trauma program manager decide who has to take what question, because those facilitators are absolutely essential, and often even additional personnel have to be brought in to answer the reviewers' questions. We're going to be loaded with questions during that chart review, well, even more than we usually come up with in when we're hitting the charts cold, because we've already seen the charts. So we're really coming with questions, and we need those answers to validate those issues that we have with the care being provided, because this is the only time we're really directly assessing clinical care. In this case, often when the reference year hasn't been updated, we're assessing care, and this happened at our centers, of patients that were managed over a year ago, almost 2 years ago at times, and by maybe providers that are not even there. So it's a little tricky, and so you need to. One of the benefits of this is the charts we're going to review. You better know them very, very well, and you better be able to answer the reviewers' questions fairly specifically, and that's so you need to train your trauma medical directors and direct them to do that prior, and be there. And if you need a subspecialist, at least have that conversation beforehand. Emergency medicine physicians, especially at level 3s, are often instrumental to be available to answer questions in regards to ED management. That session goes, as commented here, quicker than usual. It's generally, we used to leave 4 to 5 hours to do chart review on site. It's now, most of us have got it down to 3.5 hours. But and then as was discussed, the agenda then goes on to TQIP and document review. TQIP is important. It is very important to recognize you need to have some understanding of the TQIP reports, level 3s less than level 1s and level 2s. If you don't have that understanding, and you haven't, matter of fact, I would even challenge you to have used your TQIP analysis of your reports in your PI process. Remember, these outlier status that is the most significant marker of performance that TQIP provides. So if you're an outlier in whether you're a high or low outlier, it's going to be picked up and you're going to be asked about it. So if you're green or red, you better be prepared to discuss it. The documents, the document have already been distributed. We have already split them up into the lead reviewer assigns the various areas. So those documents have been reviewed. And so again, they may go very quickly through that if it's been reviewed prior, and it generally has been, and only questions of the material. In my case, it was credentialing. It was boards. Boards weren't updated in several of the subspecialties, so they were dated, and there was a little bit of, which set up a little bit of panic, but they got that done before the next day, so that all the individuals were indeed board certified. But remember that we're looking for current status of the providers' boards, not prior status. ATLS where necessary, CMEs where necessary. Also call schedules and really the documents of policy and procedure. The replacement for the dinner was probably the toughest thing to manage as a reviewer. Very, very difficult. It's like a Hollywood Squares session on steroids. You know, you really have no time to introduce everybody. So provide the reviewers with a list of attendees to this. We try to get through it in about an hour and a half. Remember, it's only a validation of what you placed in the PRQ, and making sure that those verifying that information for the VRQ committee that will review the document. And in fact, in the sessions we've been in, it's been about an hour and a half, and it moves on through all the disciplines. Unfortunately, rehab and the injury prevention coordinator fortunately has been pulled out of that and reports previous to this in the agenda, and that person has the opportunity to discuss their activities prior. I don't think that was talked about, but yes, that's also in that block of time between chart review and the meeting, I believe. And generally, we're not going to talk about PI or registry in that interview session, but some of those topics may come up. Once that's done, the second day starts with the tour. My only comments on the tour: the less we have to travel with you, or while you're traveling, it gets a little seasick for those who are being shepherded around the hospital. What we're really looking for is what your setup is. One of the things that we've done and I've done, asked for, is maps of the a hospital map sent to us in the documents so that we can look at the facility, and also an understanding of the distances between the various trauma-related areas of the hospital where trauma patients are commonly cared for. Those are important to have. Probably the most important thing is make sure you put somebody, you're putting people up that are comfortable with the situation, that are positive about their departments, are speaking to the activities relative to the trauma patient that go on there, and understand them well, and have done it repeatedly before. You have that, there's not a lot of ability from a reviewer standpoint to find other individuals to talk to. We're going to talk to who you're going to present to us, pretty much. So in that review, so that's a real change, because one of the things we did on site is look for the individuals who are caring, who are other than the group we're with. Here, you really control the situation. So I think you use it to the benefit of the institution. Once we do that, it was discussed previously that the TMD and TPM interview together. I think the agenda has them interviewing individually and then together, or the other way around. I believe that's an important thing to do, is separate the two, and one reviewer will go with one and one of the other will go with the other, and then together, and that could be discussed at any time prior to that in regards. And issues need to be discussed. Generally, the conversation, and I think all of you have gone through reviews, understand that, is not so much what you need, but what are your weaknesses? Where can you improve? That's trying to actually help you. It also is a place we'll discuss the criteria deficiencies we might have found. And this is a time to address those. And maybe we can correct them before we leave, or correct them before we have the report in. And that's very important, not to get defensive at that time, but realize that we're trying to, this is the last time we can inform you of a problem before the next session, which is not really an exit interview. It's an exit review, an exit report of strengths, weaknesses, and criteria deficiencies if they exist. And with each of these, we need to make a recommendation. And then, unlike before, where we have to get a when we have to get a cab and get to the airport, we basically hit leave and we're done. So we have 2 weeks to get the report in. The nice thing about this is we're pretty much done with the case review within days, if not that day. And the rest is really collecting everything else, all the materials, and we're getting them out in about within the first week to 10 days. The reports are back, and they'll be back to you within 6 weeks. There's an editorial process. Remember that that's not the final say. These documents go through an editor, and then who's a part of the VRC, and then are reviewed by a portion of the committee of the VRC, and then have to be voted on relative to what the verification status is, whether it passes or it requires focus review. Any questions? Alex, I hope that's where you want what you wanted. I wasn't as prepared as I would like to be. So
no, that's perfect. Thank you. I think having the perspective of a surveyor is really helpful, especially for a lot of our centers. That we have a lot of centers that have surveys coming up this year. So does anyone have any questions that they want to ask Dr. Tinkoff before we have Jenny kind of close us out with some tips from her visit? You were super thorough.
It's Shelley Aiken-Gordon from Cincinnati. It's nice to see you. We haven't seen you in a while.
Hi, how are you?
Doing well.
You know, I'm a University of Cincinnati medical school grad, by the way.
I know you are. We just passed our level 1 and 3 verifications in the last 4 weeks. So
congratulations. Yeah, I have great fondness for both centers.
All right. Well, thank you so much, Dr. Tinkoff. We're going to have Jenny Lemmink just take a couple minutes to, she just went through her level 1 verification. She's actually the second center in the state to have a virtual visit for level 1. Most of our centers have been level 3 so far. So she's just going to give a couple tips or lessons learned that she had, and then we'll wrap up.
Thanks, Alex. And the first thing I want to say to everyone is please, if you have a visit coming up or, you know, you have questions, that just reach out to me. I'm really happy to talk to people about it. If Amanda Applin's on from Toledo, she went ahead of me. I truly had planned, Amanda, to reach out and chat with you that week right before my visit, and it just got kind of crazy, and I appreciated that she had extended that invitation. But just so you all know, my background, I actually started at a level 3, so people like Melody and Vic and some that might still be on the call here, 20 years ago, we were starting a level 3. And so I know what it's like to be at a level 3. I did a consultation visit there. Then I came back to the University of Cincinnati Medical Center here, and we're under the umbrella of UC Health. So my colleague is actually Jenny Brodsky, who is at Westchester Hospital, which is a level 3. They just had their visit literally this week. So Jenny's actually on vacation. So this is actually Jenny Lemmink, not Jenny Brodsky, chatting with you all about this. We had our visit 2 weeks ago on April 20th and 21st. So looking at it from the perspective, this was the very first visit that I did everything myself, where I was the trauma program manager and did the PRQ and that sort of thing. My colleague, Shelley Gordon, who is on the line here, had been the previous trauma program manager for a number of years. She was the trauma director. She actually was our coordinator, and that actually worked out really well because it was myself. I had a new trauma medical director, Dr. Makeley, and this whole virtual thing was somewhat crazy. We had about 8 weeks to get prepared for it. So a couple of things that were difficult for us is basically all the IT stuff as it got discussed. So you have to see what you were doing at your place and what resources you have and how you were going to set it up. But things that we decided was, you know, Shelley knows what's going on, so she was our coordinator. I actually have a trauma medical director and an assistant trauma medical director. I also have 2 PI coordinators. So one of my newest PI coordinator was actually one of my navigators, and then my clinical nurse specialist, who's an advanced practice nurse, was our other navigator, who's also been here and done this for some of our past visits. But it starts with, you know, I get the email, and the first thing we discover is the admin for one of our reviewers. We had Dr. Jeff Young, who's from Virginia, and Dr. Jay Yellen, who's from New York. One of the things the ACS sent us was an admin that was actually not correct. So luckily, our program coordinator reached out immediately to confirm things. And for those who've done this for a while, working with the ACS, sometimes not helpful. Don't cross their T's, dot their I's, a little frustrated with things like that. We, you know, immediately when I got this, one of the things I did was like, I kind of like put it out on my desktop. I printed it all out. I read it. I have like 10 copies of like everything because it was so new and different. And then I had to sit there and sort of make a calendar. And I literally just laid out a calendar when everything was due, and then had a meeting of the core group of people that were working on this. So everyone kind of knew what they were going to be doing, what they were responsible for, etc. So at my hospital, we use Teams. We don't use Zoom. None of us were comfortable with Zoom. The physician side of the house uses WebEx. So at our big medical center here, our physicians are an entirely separate IT than our hospital side. So having us in rooms next to one another was not going to be our offices because we're not even using the same platforms or anything. We couldn't share anything on our shared drives. So we had to be very creative, and Shelley was extremely instrumental in helping with this and getting our IT people involved, kind of that sort of thing. So the first thing I did was I let the ACS know that we were going to be using Teams as our HIPAA compliant platform. And they're like, oh, we've had other people say that. Okay, as long as it's HIPAA compliant. Because the last thing we wanted to do was have to learn something new again. And we had really worked through a lot with our Teams meetings to try and get our physicians in on our Teams meetings and worked that all out. We were also then told to use OneNote, which again, none of us knew how to use. And that was truly a learning process. I will tell you, the 8 weeks that we had to set things up was almost not enough time for us to do all this IT preparation and get the charts together and that sort of thing. We did not do all this paper charts and scanning of things. Basically, we did everything electronic, where we use Epic here. So for those of you that use Cerner, I've never used Cerner, so I can't help you with that. But if you use Epic, I can tell you what we did. We reached out to our medical records ahead of time, knowing that this was coming, and said, we are going to give you a list of patients and things. These are things that we need. Can we do a quick trial, see how this is going to work? What does it look like when you print certain things out? And kind of did things like that. One of the other things we also did was we all got an Adobe Pro so that we could take PDFs and sort of undo them. So we could cut and paste, because what we discovered is when you upload things into the OneNote system, if it's a PDF, they all go sideways. And there's no way to rotate the view. So we're like, that's not going to work for the reviewers. The last thing you want is your reviewers having to like read everything sideways. So there were a lot of just things we just sort of stumbled upon and learned, put together. I'd love to show you my documents and my charts. Unfortunately, I couldn't come up with a good way to make this HIPAA compliant, because it's going to show you names and medical record numbers. So I'm not going to pull that up right now. But if somebody wants to reach out to me, especially if you've got something, a visit scheduled and coming up soon, and you're using this OneNote, please reach out, and I'm happy to give you some helpful hints. The other thing is, we did a lot of testing before we tried to send things, and my PI coordinator was awesome about she'd encrypt stuff, and then she'd send it to her home email to make sure that stuff would work. And despite all this, one of the things we discovered was we had our PDFs in our documents, and that created such huge documents. We literally had to break it down into 3 separate things that we basically sent to our reviewers because they were so large. The other thing we discovered, and it happened to me, and it also happened to my colleague Jenny, is that each of our junior reviewers was using a Mac. And when we sent them our OneNote, they could download it, and then they couldn't open it. And then they expected us to fix this. And this was not basically our problem. I think what it was that they just didn't have enough space on their Mac to be able to open these things. I don't know, but there's something about these Mac computers, and the ACS has not been really helpful in trying to fix this problem, nor were they really helpful with the reviewers, because the reviewers didn't quite understand what was going on. They didn't know about the OneNote. It was really very stress producing for me when I had sent all of my stuff on Monday to find out Thursday evening that my junior reviewer could not open any of the items. And basically, in talking with the ACS, there is that 4 hours of medical record review. And basically, we had our IT set up so that if that person didn't get to look at it ahead of time, we were going to do it the old-fashioned way, and you get to look at it during that 4-hour review. So that's built into the schedule. He went out, actually, I think he got a new computer overnighted to him, and he was actually able to open up then what we had done and review it before our meeting. So for us, we had a ton of physicians, of course, for our review meeting, and we had, our administration all set up for our exit interview and that. So I will tell you that there were certain things that if we got ahead on that agenda, there were certain meetings that were not going to get moved. Absolutely not. I cannot change a review meeting when I have 8 different physicians, most of whom are surgeons, and doing other things throughout the day. The same thing with the exit interview. It is on the calendars, has been on the calendars for my admin people, not going to change this. So we had actually downtime during our review, and it went much quicker for us than a in-person visit. The same thing when we did our hospital tours. So I believe the agenda is getting changed and updated to that, and halfway through our preparation, the agenda changed a bit for us and the way we were setting up meetings. The only meeting that's broken out is when there's the 2 reviewers and they're doing the medical record reviews. And for me, sending out the invitations and sort of figuring that out, I'm happy to tell people how I did that, because we still needed to be able to cross over into the different meetings in case there were questions, which there turned out not to be. But in case that was there, I can tell you how we set it up here. But again, you have to figure out what you can do at your place. The other thing, the hospital tour, was I looked at what we were supposed to have done last year and then kind of what they suggested for this year. And the other thing is they keep talking about all these staff nurses and wanting all this. Well, I was very sure to have my medical directors for all these areas that are present. And it was interesting because the reviewers ended up actually asking them a lot more questions when we were doing the hospital tour. And then I also clarified with them, because it's not real clear on the hospital tour, if you have a helipad, did they want to go to the helipad, which actually my lead reviewer had been a junior reviewer. He's been to our helipad. It's a beautiful view because it's on the 10th floor, but they nixed that. And thank God they did, because the day of our hospital tour, it actually snowed here about 2.5 inches on April 21st, which is somewhat unusual here in Southwest Ohio. And the other thing that's happening is our critical care tower was built in 1989, which I remember that, and it doesn't seem like it was that long ago. But our ED has looked exactly the same. It's too crowded. You can't close the doors. It's not warm enough, et cetera. We get that as a weakness every time. Well, they are actually building us a new ED, which was awesome. But they had to take out our decon, which is outside in a trailer. And like I said, it had snowed, and we set up our video and that sort of thing. And it was just like, oh, this is going to be even more challenging than we thought. So one of the things that we did for our hospital tour was not only did we have a wow with a camera, we also hooked up a laptop through it so that as we did the tour, we turn off the camera so we weren't making them seasick, because there is no easy way to get around our facility. It's just huge. So by having the laptop, when the reviewers were talking to people, the people that were being asked the questions could actually see the reviewers on the laptop. So it was really really nice. So not only did we have a camera so the reviewers could see the people they were talking to, the people that were being asked questions could see the reviewers. And so I'm happy to tell people how we jerry-rigged that. That worked really nice when we kind of did our little tour. For once, our anesthesia liaison was there with my OR director and our PACU manager, and that he actually took our little setup into our trauma room, OR 21, which during a normal visit, because nobody's in scrubs or whatever, we had never done before. So our anesthesia guy, of course, is in scrubs and that, and he takes our little AV equipment, off he goes with the reviewers to look around our trauma room and have some discussion about that. And that worked out really nice. So those are just some little helpful hints, tricks, things. Again, so if you use Epic, you're using OneNote, I'm hearing that that might not be a recommendation now. I don't know. Everything needs to be HIPAA compliant. You've got to run it through your IT people. There's hiccups. There's all sorts of new things. This was probably the most stressful thing I've ever done because there was so much new stuff to actually learn. And I really felt like I didn't know my charts as well because I was just running out of time for everything. I reread my PRQ last January here because, you know, we were supposed to have it more than a year ago, but some of the charts we were reviewing were almost 2 years old. And so it was difficult, but we had a really good review. And so any of the TPMs, if you want to reach out, and I can show you how we've set up our charts, because we did a lot of cutting and pasting for our PI stuff, and they loved what we did because it just flowed and it worked really well. And like I said, I'd love to show everyone, but I did not really actually have time. I took last week off. And so I didn't have a lot of time this week to actually put a presentation together. But if people have questions, please let me know. Reach out to me, you can call me. Yeah.
It's Shelley. The one thing I would tell you guys is, like everybody has said, make sure you partner with your IT people, and they can help you with all the issues, because this virtual stuff is very dependent on the IT. And so make sure you have a consistent contact with IT, with applications, and then with security. Because another thing we found out was to send the files, we had to use another program called Hitachi that none of us had. So make sure the minute you guys start scheduling this, you partner with your IT people and go, if you at all can, have an IT person with applications sitting in the room for those 2 days with you, because nobody wants to wait if something goes wrong for you to find an IT person. Dr. Tinkoff, you're not supposed to be listening to all this. You're here our tips and tricks.
I'm on the other side as well, so I have to prepare centers. I will point out you can if not all else fails, you can use encrypted flash drives, send them to the reviewers with the documents, with the caveat that they have to either return them or guarantee destruction and with of them and with evidence of that. But the fact is it can. That's centers have done that and been successful.
Ours would have just been so huge. I mean, the level 3 could have done that, Dr. Tinkoff, but I'm telling you, I don't.
I agree.
Yeah.
And the problem with our reviewer wasn't that he couldn't download it, it's that he couldn't open it. So if we had put what we had on a thumb drive, we would have had the same problem.
Yeah, no, and so I think what I said in my talk, and I want to reiterate it, is from a reviewer standpoint, give us your contact to your IT person, if we're having trouble, because that was instrumental for me in West Virginia, because they actually, I worked with Sylvester, his name was, until we could get my stuff to work. We did it 2 times, and on Monday and Tuesday of the following week from the Thursday meeting, and it worked. He got it to work.
Well, I will tell you from our end, we tried to do that, and we tried to set up a meeting with the reviewer, with our IT people, and he could not meet this. We can meet you at these 2 times. Can you meet? No, I can't meet. And then our IT people are like, we're kind of uncomfortable trying to bridge that. We'll go in under Teams and see if we can help him. But
well, I will point out that the feedback that you guys have just given, both from Cincinnati and from the previous talk, should go back to the VRC.
We're going to write a letter.
Plan. Yeah, Jenny was going to finish up her visit.
Because we have had 2 adjustments already in the as we move forward. I do believe that virtual visits will be retained to as an option, especially. But I do think site visits, my own personal opinion, site visits are very important for initial verifications and consultations.
Dr. Tinkoff, do you know for sure, we asked the reviewer, are we resetting to where we review again in 3 years, or are we resetting for 2 years?
I don't know of any discussion of resetting in an earlier time frame.
Okay. So,
but I will say that be prepared for TQIP reports to be very integrated in level 1s and level 2s in terms of time frame.
Okay.
That's just my own read of. I'm no longer on the COT. I was retired from it, and but I am on the VR. I am on the VRC program. I still am active with, but what I read, my own read of the things recently, is TQIP's going to have the TQIP reports are going to have a very strong influence on how long you may go, and there may be with, so if you have a string of poor reports, there may be we're coming, or what's up. There may be a focused review. That's because remember, there's insight now.
Yeah, we're hoping to get a sense of this, because I think I gave my trauma medical director a heart attack when I said to her, well, Amy, our review year starts January 1 for our next review if the cycle doesn't change. And her eyes got about, like yay big, like, what? Are you kidding me? Like, that's how quickly it's coming around. And so.
Yeah, and it's going to feel quick once it goes back to 3 years. Again, I think you have to be mindful that as far as level 3s, I think they're 5 to 10 years away before those become relevant, because they have to collect that kind of data. Remember, 2006 were the first TQIP reports of certain centers. But this has been, we're now 15, 16 years into accruing an enormous amount of quality data that is going to be mined and is being mined. And those performance measures are going to become more and more important in making determinations of how long. So some centers may not be reviewed for 5 years if their DQIP reports are, and that's been discussed. I don't know when they're going to pull that. I'm not going to use that term, but they're going to do that. So.
Dr. Tinkoff, this is Alex. Real quick before and see if anyone else has any questions, but do you have any word on the new book yet? Has there been any rumor coming out?
Yeah, it's a great question. We have the same questions as reviewers and non-COT members. I think the best person to ask that to is Dr. Claridge, our CO2 chair, and make sure that that information is. And I think this group has a real investment in knowing that and preparing for that. What I have heard is it's not going to go into. It's not going to be part of the the verification process until this year is over. So it's 2022. It's being projected as. So.
Gotcha. Okay. Thank you. Does anybody else have anything that they want to ask any of our speakers or questions they want of the group? I thank you everybody for staying on and especially to our speakers for coming on board.
So this is Ginger Schwen again. Hi, Dr. Tinkoff. This question is for you. Any special tips that you can consolidate for a center, hospital who's trying to start our trauma center from first time? This is, we are going to try to have our consultative visit next year. I'm working with a consultant, but any special tips and trades you have for me?
Yeah, there could be several, and the fact when you said that, the first thing that came to mind is get a consultant, and get because you're going to get a consult visit. That consultation visit is really a consultation visit to mirror the verification visit, not a consultant of how to do it. You need to be nearly operational at the time the consulting visit comes in. So when I say nearly, you need to have key people in place. The trauma program manager needs to be in place. The registry needs to be functional. You need to know that registry platform well and be able to use it for PI processes. And your PI committee needs to be identified and operational. Your trauma team activation needs to be functional. You don't have to have it operational for a year, but you do have to have it operational for a couple of months and start generating information and data about your trauma admissions, your injured patients that meet the trauma criteria, and then you're ready for your consult visit. I remember doing Westchester's visit when the Ohio State law came in. Westchester's visit was very tough because they were placed in a very tough situation of having to have a consult visit with really very little activity going on there at the time. But we were able to do that because of the seniority of some of the people that were already involved at Westchester. So, but that's that. I think from level 3 development in Ohio, that's probably your best bet to be functional. The problem is the clock starts ticking 18 months later. You have to get your verification visit in, and that's a high stakes verification visit at that time and you have only 18 months of experience. So this allows you a little bit of experience on the front end without having to go into a high stakes visit after 18 months.
Well, I'm trying to think of getting the best bang for our buck for the consultation visit, right, from you guys. So we are hoping to we're working on getting our program going and have a goal of October 1st here of having everything in place and working as if we're a trauma center. Yeah. So hopefully by the time we have our visit, we'll be working at 9 months and be able to have tweaked it by then.
October this year?
Yes, we're putting our processes in place now.
Have you asked for your consult visit yet?
That's
Yes.
coming in this
Yeah,
month.
so
It's
they're
like,
not
it's
gonna-
like a year out. It's like a year
Yeah,
out.
you're not gonna get till 22. October
Right.
is, they're
Right.
asking for October 22 right now.
No, yeah, so we're thinking next year having that, but I want us to get going, get our PI in place, our activations, our policies, our procedures,
Yeah.
and all that going first.
Yeah, that's a 12-month, that's an 8 to 12-month process.
Right. Okay, thank you.
You're quite welcome. Alex?
All right. Anybody, looks like I don't think anyone else has anything. So we'll go ahead and close out. Thank you, everybody, for taking the time to join us. Thank you, Dr. Tinkoff, Dr. Chow, Jenny Lemmink, for being our speakers. We really appreciate the great information you guys gave. Again, this session is recorded, so we will have the session for review for our OSTNL AOTR members. And so you'll see that probably within the next week. Hopefully in the next couple of days, I'll probably have it up by Tuesday, and I'll send some communication out. If you have any questions, or if you have questions for our presenters, email me or Carly Coleman. And thanks again. We'll see you guys soon.
Thank you, Alex.
Thank you.
Thank you.
Thanks.
Thanks,
Bye.
everyone.
Thank you.
You ain't ever had home.